What if your brain isn't just aging, but what if it's actually under attack? And what can you do to stop or even reverse that decline before symptoms ever show up? Today, I'm joined by Dr. Syed Asad, a board certified neurologist and brain health pioneer who's blending cutting edge detection with regenerative tools like plasma exchange to rewrite the future of cognitive decline. Dr. Syed Asad, it's awesome to have you here. And brain health, brain talk. I mean, just everything brain. I think that's a big topic right now.
Yeah, for
And
sure.
across the board. I'm sure in the medical community, but also just on the streets. With everyone. And
Yeah.
that's what I want to talk about is kind of your perspective. And, with your work, I want you to give us just a brief little background on what you've done as of yet, but also just where things are at now, but where we're going with brain health and what's even possible
Sure.
and how
Um,
plasma exchange and all that, because you've been doing it, which is really cool. But yeah,
yeah, yeah, for sure. So I will start with, you mentioned the brain is in the limelight. Maybe this is a neurologist's bias, but I think the brain should have always been in the limelight because the brain is the highest organ, right?
yeah,
It's central command. It basically controls everything, and um, so as far as the field of neurology, which is what I've been practicing for the last 20 years,
hmm
um, it started out with people being able to make diagnoses, but not being able to do a whole lot. The joke used to be diagnose idios.
uh,
And unfortunately, there's still conditions like that from Lou Gehrig's disease to Alzheimer's disease, et cetera, where beyond a certain point, there really isn't a whole lot you can do. The cool thing is that over the last few decades, there's been more and more interventions, and I think that's what pulled me into the regenerative medicine side, where I was definitely interested in treating my patients who came in with symptoms of Parkinson's or symptoms of dementia. But I was always fascinated with the idea of how about if we prevent this from happening in the first place? How about if we figure out that someone is headed in that direction and do certain things where we can avoid this? Or once it starts, what can we do to prevent it from getting worse? And I'm not just talking about symptomatic treatment, I'm talking about actual disease modifying treatment.
can you break down the difference between symptoms? I think that's fairly obvious, but the disease modification, the second part there. Yeah, I'd love
Sure.
to.
Yeah. Yeah. So I'll give you an example. With Alzheimer's disease, it's a complex pathophysiology, but in short, you've got these two bad proteins. You've got hyperphosphorylated tau, and you've got beta amyloid that basically clumps together and forms amyloid plaques. The amyloid's outside the cell, the tau is inside the cell,
Mm,
and these two, along with inflammation and other things, damage the neurons or kill the neurons. And that's basically the decline that you see
mm,
in people who have Alzheimer's disease. So symptomatic treatment would be something like donepezil, which is a medicine that increases acetylcholine in the brain, which is nice. If you give the brain more acetylcholine, it functions a little bit better. But you're essentially rearranging the deck chairs on the Titanic. The Titanic, unfortunately, is going down. And so disease modifying treatments would be a way to figure out that once those amyloid plaques start forming, or once the neurofibrillary tangles with the tau start forming, what can we do to make sure that process doesn't persist? Or maybe even figure out when a person is heading in that direction to avert it altogether.
mm.
And
Yeah.
that's where a disease modifying treatment would come in.
Interesting. Okay. And yeah, we already seeded that you've been using plasma exchange for a while. You said for what, 20 years, right? Thereabouts.
More.
So
Yeah.
we'll seed that for just a little bit. I want to go a little kind of set the scene a little bit more. But
Sure.
that's already intriguing, is how it's been used and how you're now doing it. I'm curious on the detection side. Like,
Mhm.
I guess what's the approach? Are there new improvements now? And I guess what are the tools? How is it done?
And are you specifically talking about dementia?
I guess with any kind of neurological disease, like where would you start? And maybe what are some of these symptoms where you're finding people, like what's the first step when you see someone? You're like, okay.
Sure. Yeah. So broad categories with neurology are there's the central nervous system, which is the brain and the spinal cord, and there's the peripheral nervous system, which is the nerves that come out of the spinal cord and basically connect with muscles at the neuromuscular junctions and spread from there. In broad strokes, you've got diseases of the central nervous system like dementia, like stroke, like epilepsy, like multiple sclerosis. And then you've got diseases of the peripheral nervous system like neuropathy and myasthenia gravis. So when you're approaching a patient with neurological conditions, you first localize where the disease is. Then you come up with a differential diagnosis of possibilities. Then you test your diagnosis. If it's a central nervous system disease, you might want to do an MRI. You might want to do a spinal tap. You might want to do blood work. If it's a disease of the peripheral nervous system, you might want to do an EMG nerve conduction study. So there's different testing modalities. As time has gone on, the technology has gotten better and better. And so we just hopefully are doing a better job of nailing down the diagnosis. And in the case of neurodegenerative diseases, if we make the diagnosis ahead of time, so for example, let's say someone who would normally start having memory problems, let's say in their mid-60s, and they would go to their primary doctor, then they would go to a neurologist, then they would get, testing, cognitive testing, scans, etc., and they would get a diagnosis. Let's say someone has an ApoE genetic test of E4E4. That puts them at high risk for dementia. Let's say they're only in their early 50s right now, and with that genetic profile, they get blood work that shows that they're also already spilling amyloid and tau proteins from their brain into their bloodstream. And then you do an amyloid PET scan that shows amyloid deposition has already started in their brain. They're cognitively completely normal, but they're showing signs of early dementia. Well, that would be the time to strike. And if you can remove either the factors that trigger the amyloid and tau pathology in their brains, or have a mechanism to remove those bad proteins or stop their accumulation, by the time they reach their mid-60s or beyond, you might actually change the direction of where they're heading.
Interesting. Okay. So yeah, I've definitely heard of that gene. So basically having a genetic profile, and you said would that be a blood test primarily where you?
Yes. The E4E4, that would be on a blood test.
Blood test. Okay.
And now, I mean, the amyloid and tau are serum markers as well. When I was in training, we would do spinal taps to look for amyloid and tau. And that's fine. I mean, that's a good way to do it as well. But yeah, a lot of people don't want to be poked in their backs. And so
a little bit more aggressive.
Blood works. Yeah, a little more invasive. So blood works easy.
I got you. Okay. Well, that's interesting. So detection, lots of ways to go about it. It makes sense depending on what's going on. Mm-hmm. Are you seeing trends? Like, are there different trends now in the world we're in? Like, are these types of diseases popping up earlier or in different ways? Are there maybe more often cases that you're seeing than before?
Yes. If you look at the epidemiological data, there are more and more cases. Now, some of that could be related to the fact that we're living longer. So for dementia, for example, the longer you live, the higher the probability that you'll end up with dementia. Some of it may just be better diagnostics, where back in the day, maybe people didn't even realize that, they had these issues going on.
True.
Especially in mild cases. But there is definitely an increase in prevalence of these conditions, and that is probably related to many of the risk factors. So there's, in this day and age, people are more sedentary than our ancestors were. That's just because we live in a comfortable world and, don't need to work as hard as our ancestors did. There's foods that we're eating or lifestyles that are promoting more what we call vascular risk factors, which can be a risk factor for neurodegenerative diseases. There's pollutants and toxins. There's processed foods. Um, there's more inflammation,
Yeah.
and also just in terms of, one of the things I always talk to my patients about is sleep. Sleep is foundational. We are designed to spend a third of our life sleeping.
Yeah.
That's 8 hours out of every 24 should be dedicated to sleep. And that's not by accident, that's by design, because sleep is not just restorative to the brain, it repairs the brain. And nowadays, I love coffee too, and I enjoy watching TV and, video games, whatnot. But if we overdo it, if we do those things to the detriment of our sleep, if we don't make sleep a priority, then we pay the price. And that also increases the risk of at least neurodegenerative diseases.
I want to tap in on the sleep part because honestly, like I know I think it's just a lot. I I like to say I think I'm kind of normal in this. Like I know I don't get enough sleep,
Mhm.
but I think it's because of the activity. It might be the phase of my life with kids too, young
Mhm.
kids around. But
Sure.
I don't want to give excuses here. Like, what's your protocol to sleep? Like, just lay it on me the most.
Yeah, no, so it's interesting. When I was in training, and this is again not a very long time ago, just over 20 years, um, we used to be told during the residency training that sleep is overrated. In other words, in healthcare, we were told, you know what, you guys, if you're on call for 36 hours, that's okay. You don't need to sleep. Just do your work.
Mhm.
And I think that was noble in terms of like, trying to take care of patients at night when,
Right.
but the problem is, eh, if you continue that for too long, if you really deprive your brain of sleep, and especially components of sleep like deep sleep and REM sleep, there's certain things the brain does during those phases that are lost when you're not getting those phases of sleep. So it's not just the quality, it's also the it's not just the quantity, it's also the quality.
Sure.
So you were asking what's a good number. So we have this ultradian rhythm, this 90-minute rhythm during the day and at night. So,
Hmm.
for example, when you're sleeping, your brain goes through stage one, two, three, rapid eye movement in 90 minutes. And if you get about five 90-minute cycles, that's pretty healthy. So that's 7.5 hours.
Hmm.
And if you wake up and you were just dreaming and you finished that dream and then you woke up, that means you just finished that 90-minute cycle, and generally you'll feel good. If someone wakes you up out of like REM sleep, you're not gonna like it, and you're
Groggy and
gonna have,
everything.
yeah,
Yeah.
you're gonna have that sleep latency. And so for most people, that's a good amount. But what I also tell people nowadays in the age of Apple Watches and Aura rings and whatnot,
Yeah.
I tell people, and I do this myself, and I actually show them my sleep data, and I tell
Cool.
them I'm not showing off. I'm just telling you that you can do this as well. Is monitor to make sure that the combination of your deep sleep and REM sleep should be about 40% of your total sleep time, and
Mm.
that's a healthy amount.
Oh, that's
So
super helpful. Thank you. Yeah,
yeah,
because
absolutely.
one with an Apple Watch that I'm always looking at the metric. I don't necessarily now I know. Uh,
Yeah.
I mean, that's great. And is there a timing that you like to shoot for going to bed, waking up? Is there a window?
Yeah, so I use both the Apple Watch and the Aura Ring,
Uh-huh.
and the Aura Ring actually tells you your chronotype. So once you've worn it for 3 months or more, it'll figure out your chronotype. So your chronotype is the ideal go to sleep time and wake up time for your brain.
Got it.
And it actually varies from person to person, and it's good to know what yours is.
Mm.
And this goes back to the time where we probably lived in groups or tribes, and the saber-toothed cat could attack at night, and so someone had to keep night watch, right? So within the
Uh-huh.
same family, people will have different chronotypes. So I always knew that I was someone who went to sleep early and woke up early. And sure enough, my wearable told me that I'm supposed to go to sleep at 9 or 9:30 and wake up at 5,
Yeah,
which is what I do anyway.
it's natural. Yeah.
Yeah, but it determines that not just based on your habits, but based on your heart rate and based on your temperature and based on a whole host of other parameters. And it figures out what your ideal is. And so I think I encourage everybody to figure that out. my daughter, who's 22,
Mhm.
and she's doing her master's degree right now, she figured out that her chronotype is go to sleep at 1 a.m., get up at 9 a.m. And so I told her she's learning video game design. So I was like,
Cool.
no, that's a cool field where you can choose your hours, hopefully.
Yeah.
So just choose, a job where you can basically stick to your chronotype, so you don't have to compromise how your brain is wired.
I've seen that for me, and it's a little later at night, and I'm like, nah,
Yeah.
I can't be right. You know, I've always heard earlier, and but
Yeah, no,
to your
so it's
point,
not
yeah,
one size doesn't fit all. And I think in society, we've kind of been, again, trained that you should get up early and you should go to sleep early. And that's not true for everybody. You have to figure out what your chronotype is and hopefully design your lifestyle according to how your brain is wired.
that's right. I mean, kids though are that wild card where you're just like, oh gosh, but it's the season, so
Yeah, yeah, yeah. No, I've definitely been there. Mine are 22 and 19, so it
yeah,
gets
yeah.
easier.
Thank God. So, well, and you mentioned inflammation as well, because of
Yep.
course, inflammation is the root of what basically all disease, right?
Agreed.
Yeah. So
Agreed.
talk to me, like, how do you think about inflammation? Then I'm also thinking of, obviously we want to reduce inflammation. There's a
Yeah.
healthy component to it, but how does that relate to what you're seeing in neurological diseases?
I'm going to answer that question, but I'm going to talk about something else first. So
Do it.
I did a certification in acupuncture like 15 years ago,
Mhm.
and I was always fascinated by it, but I thought I was just going to learn another medical modality. But it's a 3,000-year-old art, and the philosophy behind it was fascinating to me. So I practice a little bit of acupuncture,
Cool. Yeah.
on my patients, mainly just neurological indications. But in acupuncture, they talk about balancing the forces, right? So there's yin and there's yang, and you want balance. Now, in medicine, we call that homeostasis, and everything needs to be in homeostasis. Everything needs to be in balance, right? And so, for example, we have the autonomic nervous system. There's sympathetic and there's parasympathetic. Rest and digest, fight and flight, right? And if you are too hyperadrenergic and too hypovagal, that's a problem. So you wanna bring balance to the force. And your question was about inflammation, and like you said correctly, you want to have inflammation so that when you get injured, inflammation is what repairs the injury.
Yeah.
But you don't want that to turn into chronic inflammation, which, like you said, and I agree, is the root of almost every malady that we have out there. And especially in the brain, that ends up being a huge, huge problem in a lot of conditions that we see.
Hello, my name is Carrie Stewart, and I did the brain protocol for the MD Lifespan. I was struggling to recall names of couples, and so I shared this with the doctor. That's when he introduced me and said, I think you're ready, and let me explain to you a TPE, because this is going to help your memory, your focus, your clarity, and I truly believe you'll be a wonderful candidate for this. I have had 5 TPE protocols, and each time I have improved. And it's not until this last one that I am feeling so back on top of my game. Like my brain fog is gone, I am focused more, I have more clarity. This was life-changing for me, and I feel so much better for it.
Do you feel like there's a better grasp these days with things like plasma exchange to, I guess, to attack the chronic inflammation?
Yeah, so interestingly, we were talking earlier on about the fact that in neurology, we've used plasma exchange for a long period of time.
Yeah.
And interestingly, the indications are mainly for inflammatory and specifically autoimmune conditions. So in myasthenia gravis, for example, people develop antibodies that start attacking their neuromuscular junctions. So where the nerve ends, there's a synapse, and then it connects to the muscle. And at the nerve ending, the nerve releases, when the action potential gets to the nerve ending, it releases acetylcholine. The acetylcholine crosses the synapse, attaches to the acetylcholine receptors, and activates the muscle. Well, in myasthenia, you have antibodies that attack those receptors and damage the receptors. So the nerve is not able to activate the muscle, and it tends to have a predilection for certain parts of the body. So people start noticing their lids are drooping, their eyes are not working together, so they have double vision. They can't swallow, they can't talk. Their arms and legs are weak, they can't go upstairs. So, and in severe cases, it affects the muscles of breathing. So if they can't breathe, they end up in an emergency room with a tube down their throat. So it can be a pretty severe and debilitating condition. So with myasthenia gravis, for a long time, we've used plasma exchange where we'll take their blood out, remove the plasma that has those bad antibodies, and put normal saline albumin and put it back into the system. And in that way, we clean their blood of these bad antibodies or autoantibodies that are attacking their receptors. And again, that's true for other autoimmune conditions as well. I was mentioning CIDP, which is short for chronic inflammatory demyelinating polyneuropathy. That's a little bit of a mouthful.
Yeah, I'll look it up later. That's good.
But in that condition, you have antibodies to the myelin on the neurons, and it rips the myelin off the neurons. By the way, the acute version of that is also known as Guillain-Barré syndrome or acute inflammatory demyelinating polyneuropathy. And so in those conditions, you can do the same thing. You can use plasma exchange to remove those bad antibodies. The cool thing is that when you're doing plasma exchange, if you can also remove other inflammatory proteins or peptides, if you can remove toxins, if you can remove microplastics, if you can remove mold, then you're really getting way more benefit than what we previously thought.
Yeah. There's an episode maybe a few back where I went through my own toxin test. It was actually Dr. Savage went through mine. Oh, did you? Yeah.
I did.
You know all about me then. I don't need Yeah. Got a lot of mold in me. About to get the TPE very soon though, at least the first of 4. So
it'll be fun. Both.
Oh, really? Okay. So
I'm in the process. Well, I'm getting my test tomorrow, so we'll see.
Oh, very cool. Well, there you go. You learn a lot. Have you ever had one before? Toxin test?
No. I mean, because it's one of those things. I've always practiced traditional medicine, and again, I still practice traditional medicine. But I started getting interested in regenerative medicine, I want to say maybe 4 or 5 years ago, so it's pretty recent. And started going to the meetings, and it was an eye-opener because a lot of things that we just don't think about as the potential triggers for a lot of conditions that we see. I feel like we're not really paying a lot of attention to those things, and then we're just treating the disease once it already happens.
So since that shift, I mean, it hasn't been too long, 4 or 5 years or so. What has, it's almost like what has surprised you? And then maybe as a second bit, what are you doing differently now with that new info in your practice?
The evidence is staggering. I think that's the part that surprises me. It also surprises me that unlike people like Dr. Savage and Dr. Lee, more people are not waking up to this. And I'm talking about healthcare professionals. And maybe because we're just kind of so hyper-focused on what we're doing that we're not looking outside the box and just doing things the way we've always done them.
You're in your bubble in a way.
You're in your bubble. Yeah. I'll give you an example. Okay, so Parkinson's disease, right? Alzheimer's is the number 1 neurodegenerative disease, and Parkinson's is number 2. So that's pretty important as well. Mitochondria are the cells in all, are the batteries in all of our cells, right? Whether they be neurons, muscle cells, any cell in the body, energy is produced by mitochondria. So mitochondria is what drives that cellular activity. And what happens in Parkinson's is that pesticides will affect the mitochondria, which power the vacuoles that eat up the bad proteins. So now the vacuoles are not getting powered up. And so alpha-synuclein, which is one of the proteins that causes Parkinson's, is piling up inside the neuron and damaging the neuron. And particularly there's neurons in what's called the striatonigral tract that is sensitive to this particular issue. And so when the striatonigral cells start degenerating, and stop producing dopamine that goes into a part of the brain called the basal ganglia, people start presenting with loss of facial expression, tremors, shuffling gait, right? So when the patient walks into my office and they've got a masked face and they're have rest tremors and they're, shuffling, and I'm like, oh, you have Parkinson's. And I can do a scan, I can do a DAT scan to confirm it, or I can make a clinical diagnosis. And then how do I treat them? I give them different forms of dopamine, because dopamine, the neuron that's not producing dopamine, is causing these issues. So when I give them a dopamine type drug, either a dopamine agonist or carbidopa levodopa, I can improve their quality of life.
Yeah.
Am I going to stop doing that for my Parkinson's patients? Absolutely not. If it's improving their quality of life, I still want to do that. But how about, rewind like maybe 10, 15, 20 years from the onset of this condition, and if they are heading in that direction, are we able to power up the mitochondria and maybe improve the vacuole, the vacuole function, the vacuum cleaner function, and prevent that pathology from happening in the first place? And those are some of the things that got me into utilizing hyperbaric oxygen and molecular hydrogen and near-infrared light therapy, and because a lot of them are modalities that decrease reactive oxygen species, decrease inflammation, improve mitochondrial function, and those are things that people can do while they're healthy.
Sure, yeah.
But if they have a predisposition, genetic predisposition, for example, to these conditions, they can hopefully avert it or at least mitigate it.
Do you see regeneration happening on that level as well, like when going through some of these treatments?
Yeah, so most of when we talk about neuroregeneration, a lot of what we're talking about is brain plasticity. So, for example, if someone has a stroke, a part of their brain is damaged. Unfortunately, that part's not coming back. So we do things for secondary stroke prevention, so ways to prevent another stroke from occurring,
Right.
but also retraining the parts of the brain that are not damaged to compensate for the parts that are damaged.
Oh, that's interesting.
Yeah, so we do the same thing in brain injury medicine as well, and that's helpful. When I was in training, we were taught that once you lose neurons, they never come back. They're gone forever. They're super specialized. That has since been proven wrong. Okay, so now we know that you can actually grow new neurons in parts of your brain, like the hippocampus, which is the memory part of the brain. And one of the ways to do that is to, there's a substance in our bodies called BDNF, brain-derived neurotropic factor. And one of the best ways to get BDNF is regular cardiovascular exercise. So there's, so to your question about regeneration, there's also some evidence for neuroregeneration with modalities like hyperbaric oxygen therapy. So again, there's not going to be one treatment that's going to work for everybody. You're probably going to have to try to attack it from all sides. And that's always been my, modus operandi. Like for my patients, I've always started with, listen, lifestyle is important. So diet, exercise, sleep, stress reduction, managing triggers, let's start there. Let's lay that as the foundation. Yeah. And then, if there's supplements, if there's medications, if they help, absolutely. If there's therapies that help, let's bring that on. If there's interventions, procedures that help, let's bring that on. And that's why I'm excited about plasma exchange, because that's one more modality. Do I think it's the end all be all? No, but do I think that it's a really, really, exciting treatment modality that potentially can be initiated early on, and even as the disease progresses, to mitigate the symptoms and potentially be disease modifying. Yeah, I'm excited to see how it goes.
Yeah, it's early, and I'm sure there's more applications to come in the future as well.
hmm
And then paired up with a protocol that you're probably already doing, maybe adjust it or put it in this, I don't know, a different part of it, of the process.
I know you're going through the process.
Yeah.
I'm excited to go through the process, partly because I do want to see what kind of toxins I have. I want to see if the treatment removes those toxins, but I want to walk through that process because when I send my patients into this, I would like to know what they're going to be going through.
Yeah. And once I do it, I'll just put it on the record. I will talk about it. Like I've
Same.
already
Same.
put the toxins out there. Might as well talk about everything else. I really don't care.
Yeah,
But I want to
for
help others. And yeah, it's such a exciting time. I guess and just to wrap up, like, well, my takeaway, I'll just say this is like we all have the ability to do things like move more, sleep more, or higher quality. It's almost like do the things that you have the ability to do. That
Yeah.
you have that control. Not saying we can all do that perfectly, but at least you're in that control more or less, right? That part of it.
Yes. And it's funny. So I used to get patients, and we do some screeners. One of them's called a PHQ-9 to see if they have depression or vegetative signs of depression. And I tell them, listen, you're really depressed. I need to put you on an antidepressant. And they're like, Doc, I've heard all kinds of bad things about antidepressant side effects and whatnot.
Yeah.
I'm like, okay, well, why don't you use my favorite antidepressant? They're like, what's that? I'd say hit the gym 6 a.m.
Yeah.
And so while I was sincere in my recommendations, but what my patients taught me over the years is some of my really depressed patients, they were like, Doc, I don't even have the motivation to get up and brush my teeth in the morning. Okay.
Oh, wow. Yeah.
How do you expect me to hit the gym at 6 a.m? And I'm like, yeah, that's easy for me to say because I don't have that problem. But for a lot of people, they're stuck on square one because they're just very, very depressed. And people think of depression as psychiatric and psychological. I think of it very much as a neurological issue. In fact, I think of psychiatry and neurology as basically an arbitrary separation of a continuum, right?
Yeah.
Because the amygdala is part of the brain, the frontal cortex, prefrontal cortex is part of the brain, the limbic system is part of the brain. So as far as I'm concerned, those are all brain conditions. And now we know that in severe chronic depression, there's inflammation, right? In PTSD, there's inflammation, right? So it's not just like we tell people, oh, it's in your head, get over it.
Oh, yeah.
It's not that easy. So I guess point of saying that is if those people can be helped with removing the inflammation that is at the heart of these conditions, then we can get them moving. Now,
Yeah.
I always tell people if I treat them like with my brain injury patients and they get better, I don't need for them to be on the symptomatic medicines forever. We can taper off the medicines. They're just a means to an end.
Right.
But if those medicines are going to get them going, cognitively, mood-wise, better sleep, better control of headaches or other pain issues, then let's do that. Once we get them better, start putting more lifestyle stuff in there and reducing the medications because the medicines are not the goal.
Yeah, I think that's actually a great way to wrap up our chat, just because you said it in a perfect way. It's a great balance of everything. It's because I know there's a lot of fear, with folks starting medication. Some people less of a fear, but yeah, it's a continuum. It's all connected. Yeah.
Yeah, and understandably so. I tell patients I'm very conservative when it comes to medications because I do realize that there's effects, but there's also a list of side effects.
Yeah.
And but we always try to make sure that there's the risk benefit ratio favors utilizing a medicine. And again, I also draw the distinction between disease modifying drugs and symptomatic drugs. I'm not against symptomatic drugs, but if someone has high blood pressure and untreated hypertension is the #1 modifiable risk factor for a stroke, I really want them to get their blood pressure under control. Now, whether they do it with diet or exercise or medicine or all of the above, doesn't matter. Those numbers need to be perfect.
Yeah.
But if it's a pain issue and it's mild and they can tolerate it and they can manage the pain with physical therapy and exercise, absolutely, why not?
I love it. I mean, just to wrap this up, do you have any place where you would love folks to go explore a little bit more about you, what you're doing, things you're putting out into the world?
Yeah, absolutely. They could go to our website. It's universalneurocare.com.
Uh-huh.
And so it has some of the, it has all of our colleagues, and it has all the modalities that we have, and some of the things that we're moving into. So yeah.
Very cool. Yeah, I'll put that in the show notes as well. That'll all be linked up.
Awesome.
Dr. Syed Asad, this has been great. I mean, I'm going to go sleep. I got to go. How about naps, actually? I'm going to wrap it on that. Like, yes, no, naps?
Okay, so if you look at the circadian rhythm, it basically, all your hormones and blood pressure parameters and everything else goes up, then it comes down a little bit, and there's a smaller rise, and then it goes down. So it's like, we call that the diurnal rhythm.
Yeah.
And so in a lot of cultures, in a lot of human cultures, an afternoon nap would be part of their routine, right? Like the siesta.
Yeah.
And so that's fine if, again, depending on what kind of work you do, like I wouldn't be able to do it at work, but I know Google has, Google the company, don't they have like those pods that
They do. I've been there before. I've seen.
Oh, yeah, there you go.
Yeah. And I love siesta. I've been to Spain too, and I'm like, man, I love the siesta concept. Why don't we have it here in the States?
Right. So,
But
so I think if someone can do that, there are some recommendations though. So if you complete a 90-minute cycle during your mid-afternoon nap, that takes away your brain's appetite for sleep at night. So if you have that tendency where you take a 90-minute nap but then can't sleep at night, it's better if you are taking a nap to limit it to 20 minutes, because then that doesn't mess up your appetite for sleep at night. So
that makes sense.
We recommend like even setting an alarm and making sure you get up in 20 minutes.
Awesome. Okay, cool. We're leaving it there. That was just like an open loop in my mind. I had to close it. So, all right, Dr. Asad, I appreciate your time so much. This has been great.
This was fun.
All right. Thank you.
Thank you.